Welcome to the Explainer. Okay, let's just dive right into this. Today, we're decoding a deeply fascinating and honestly quite complex medical mystery. We're looking at an autoimmune blistering disease called pemphigus. But we're not just going to read textbook definitions at you. We're going to treat this explainer like a true diagnostic journey. We'll examine the clues, try to understand this ultimate cellular betrayal, and figure out exactly how medical professionals step in when the body's own defense system basically goes rogue. So here's our clinical roadmap for today. We'll kick things off with an overview, break down the mechanisms and classifications, check out the clinical presentation, walk through the diagnosis, and finally wrap up with treatment and prognosis.
Starting off with Section 1, Overview, the body against itself.
Let's start with the big picture here. Pemphigus isn't an infection, and it's not an allergy. It's a chronic autoimmune condition where your immune system literally turns its weapons against your own epidermis. To understand this disease, you have to understand exactly how that damage happens, and that brings us to the absolute core concept of this whole thing, acantholysis. Imagine the cells of your skin are like a brick wall, right? And there's a very specific type of mortar, a cellular glue holding those bricks tightly together. Well, in pemphigus, IgG autoantibodies mistakenly attack and dissolve that exact glue. The bonds holding the skin cells together just melt away. That's acantholysis. Without that glue, the skin literally falls apart, fluid rushes in, and you get these severe blisters.
Now, you might be wondering who actually gets this. It's generally a disease of middle age. The peak onset hits right between 50 and 60 years old, and it strikes men and women in pretty much equal numbers. But statistically speaking, there is a significantly higher incidence rate among populations of Jewish descent. To put that into perspective, in some areas, the rate can be up to 32 new cases per million every single year in this demographic, compared to a baseline of less than 1 to 5 per million in the general population. Moving on to Section 2, Mechanism and Classification, Locating the Betrayal. Okay, so we know the cellular glue is under attack. But to make sense of the different variations of this disease, we have to look at exactly which type of glue is being targeted. These glue molecules are called desmogleins, and we have two main targets to focus on here: desmoglein 1, or DSG1, and desmoglein 3, or DSG3. It's like a real estate issue. It's all about location. DSG1 is mostly concentrated in the superficial, upper layers of the epidermis. DSG3, on the other hand, is found deep down in the lower layers of the skin, and crucially, it is highly concentrated in the mucous membranes. Think the inside of your mouth. The specific type of pemphigus a patient gets depends entirely on which of these two molecules their immune system decides to go after. Because of where those target molecules live, the depth of the resulting blister actually determines our classification. If the attack happens deep in the skin, near the basal layer, we get deep pemphigus. This includes Pemphigus vulgaris and Pemphigus vegetans. And listen, Pemphigus vulgaris is the heavyweight here. It's the most severe form, making up a massive 70% of all cases, and it's uniquely linked to other autoimmune issues like myasthenia gravis or thymoma. On the flip side, if the attack is higher up, we get superficial pemphigus, which covers Pemphigus foliaceus and Pemphigus seborrheic.
Let's hit Section 3, Clinical Presentation, the crime scene.
Now that we've got the molecular mechanics down, let's step into the clinic and see what this cellular betrayal actually looks like in a patient. Since Pemphigus vulgaris is the most common and the most severe, we're going to focus heavily on that. Deceptively, you'd probably expect a skin disease to start, on the skin. But in about 50 to 70% of cases, the very first sign is actually painful oral mucosal ulcers. These are raw, stubborn erosions that can show up to 5 whole months before a single spot ever appears on the skin. And the pain? It's brutal. It makes normal eating and drinking incredibly difficult, which leads to rapid weight loss and physical decline right out of the gate. Eventually, the attack is spread to the skin. The signature here is the sudden appearance of large, flaccid blisters on otherwise totally normal-looking skin. And by flaccid, I mean they are loose, droopy, and easily collapsible. Because that cellular glue is just gone, the roofs of these blisters are incredibly thin and fragile. They rupture super quickly, leaving behind these raw, bleeding erosions that simply refuse to heal. This is also where a vital clinical test comes into play, the Nikolsky sign. If a doctor presses a finger on seemingly normal skin near one of these blisters and just pushes slightly, the top layer of skin literally shears right off. A positive Nikolsky sign, that's a massive red flag for pemphigus. Now, if we compare typical Pemphigus vulgaris to its much rarer cousin, Pemphigus vegetans, we see a really fascinating shift. Both of these are deep forms of the disease, but vegetans heals in a totally different way.
Instead of leaving flat erosions, it forms these wet, cauliflower-like papillomatosis masses, and it really tends to hide out in the large folds of the body, places like the groin or the armpits.
Let's also quickly touch on those superficial variants we mentioned earlier, foliaceous and seborrheic, because these target DSG1, which, remember, isn't really prevalent in mucous membranes. Patients with these forms generally get spared from those agonizing mouth ulcers. Instead, they present with smaller, scaly, crusty blisters. Pemphigus seborrheic, which is also known as Senior-Usher syndrome, actually features a lupus-like butterfly rash across the face, along with thick, greasy crusting on the chest and back.
Section 4. Diagnosis. Solving the mystery. So say a patient walks in with these terrible blisters. How do we prove beyond a shadow of a doubt that it's actually pemphigus? Well, getting a definitive diagnosis means we have to take several boxes. Step 1 is clinical observation. We're looking for older age, flaccid blisters, and that positive Nikolsky sign. Step 2 is a Tansk smear. Doctors scrape the base of a blister and check under a microscope for those round, separated acantholytic cells. Step 3 requires a deep biopsy for histology, just to confirm the blister is genuinely forming inside the epidermis. And finally, Step 4 locks the whole case down. We use immunofluorescence to literally look for a glowing, network-like web of IgG antibodies wrapped around the skin cells. And we run ELISA blood tests to detect those specific anti-DSG1 or DSG3 antibodies floating right there in the bloodstream.
Going through that exact pipeline is absolutely crucial because we have to rule out clinical lookalikes. Take During's disease, for example. It presents with grouped, intensely itchy, tense blisters on a really red base, usually in teens or young adults. Plus, the Nikolsky sign is negative. Then you have bullous pemphigoid. That one features very large, tense blisters that don't pop easily, usually hitting folks over the age of 60. And again, the Nikolsky sign is completely negative. Pemphigus really stands out from the pack with its flaccid, easily ruptured blisters and that definitively positive shearing of the skin.
To really cement that difference, just picture how tense and tightly clustered the blisters of Duhering's disease look on inflamed skin, like on the hands. Contrast that in your mind with the incredibly loose, raw, spread-out erosions of pemphigus we were talking about earlier. Visually distinguishing these conditions isn't just trivia, it's literally the first step in saving a patient's life.
And finally, Section 5. Treatment and prognosis. Halting the betrayal.
Once the mystery is solved and we have our diagnosis, the clock is ticking to stop the immune system's ongoing betrayal. The treatment protocol here requires a multi-front attack. On a local level, doctors will use antiseptics like dilute potassium permanganate just to stave off secondary skin infections, and they'll heavily rely on xylocaine gel to numb those agonizing mouth ulcers so the patient can actually get some food down. But the real war, that's fought systemically. Doctors have to forcefully suppress the rogue immune system using moderate to high-dose corticosteroids, and they often pair those with heavy-hitting immunosuppressants like cyclophosphamide or methotrexate. On top of all that, patients have to be hypervigilant about avoiding known trigger drugs. Even common antibiotics like penicillin or rifampicin have been known to kickstart massive pemphigus flare-ups.
Honestly, we cannot overstate the severity of this condition. The prognosis without medical intervention is, frankly, grim. If left untreated, pemphigus is continuously progressive, and patients typically succumb within 6 months to 2 years. This is usually due to overwhelming secondary infections or massive fluid and electrolyte imbalances from all that raw, exposed skin. Now, while corticosteroids have absolutely dramatically improved survival rates, they are a serious double-edged sword. Prolonged hydrosteroid use brings its own potentially fatal risks, severely suppressing the immune system and leaving these patients highly vulnerable to deadly pneumonias and sepsis.
All right, to wrap up this explainer, let's put your newly acquired clinical recall to the test with a quick question straight from the medical texts. Which disease always features a positive Nikolsky sign? Is it A, bullous pemphigoid, B, During's disease, C, erythema multiforme, or D, pemphigus vulgaris? Take a second and lock in your answer. All right, to wrap up this explainer, let's put your newly acquired clinical recall to the test with a quick question straight from the medical text. Which disease always features a positive Nikolsky sign? Is it A, bullous pemphigoid, B, During's disease, C, erythema multiforme, or D, pemphigus vulgaris? Take a second and lock in your answer.